morning. I'm Terry Roselle from the Department of Bioethics and the Center for Practical Bioethics, and I welcome you who are here in the classroom, the second year class at KCU. I welcome you who are watching online, either live or recorded sometime in the future, to welcome you to our sixth in a series of 8 lectures we call Current Issues in Bioethics. Our lecturer today is Dr. Lainie Ross. She is a philosopher, ethicist, and a pediatrician. And I think in that order, not that order, the other way around. Her daddy died just a few weeks ago, sadly. Mr. Friedman was an engineer who had wanted to be a doctor. He became an engineer instead and thought that his daughter should become a doctor. And once she was a doctor, he said, "You can do anything you want to do." Once Dr. Ross was a physician, she wanted to be a philosopher. I'm not sure that that's what her father had in mind. But she became a PhD philosopher, and in fact, he was surely proud of what his daughter has become. Dr. Ross is a professor of clinical medical ethics, professor of pediatrics, medicine, surgery. She is the associate director of the McLean Center for Clinical Medical Ethics, co-director of the Institute for Translational Medicine, all at the University of Chicago. She writes and speaks about ethics and policy issues in organ transplantation, donation, genetic testing, pediatrics, human subjects protections, and other issues. Today, Dr. Ross is speaking to us about genetic testing and screening of children. Children are not canaries. We welcome to the podium Dr. Lainie Ross.
Thank you very much, Terry. Can you all hear me? Great. So actually, I'm going to prove to you today that children are neither canaries nor tomatoes. But let's start at least with canaries. And this is a picture from the Museum of Science and Industry. So back in the days of mining, the miners would bring a canary down because as long as the canary was singing, they knew that the air was safe. And when the canary stopped singing, they realized that they needed to get out of the mines real quickly. And I'm going to argue that we shouldn't be testing children to try to find out information about their families or their parents or anybody else, that if you want to test parents, test the parents. Do not use children as canaries. So let me begin by telling you what my objectives are today. I have 3. I'm going to review the historical justification for newborn screening. I'm going to then look at the pros and cons of new proposals to expand genetic testing and screening of children. I'm going to look at predictive genetic testing, and then I'm going to look at the whole issue of whole genome/whole exome sequencing. I have nothing to disclose. Although so this is a caveat, I was a member of the American Academy of Pediatrics Committee on Bioethics at the time that they needed to rewrite their statement on genetics. I also was a member of the American College of Medical Genetics and Genomics Social Ethics and Legal Issues Committee. And I suggested to the AAP Committee on Bioethics that they should write a statement and that I would take the lead. And I told the American College of Medical Genetics and Genomics that they needed to update their statement and that I would take the lead. So Lainie Ross from the Committee on Bioethics talked to Lainie Ross, the committee member on the American College of Medical Genetics, and we agreed we would write the paper together. I thought that might look suspicious, so I added a few other authors, and by the end, both committees signed on. Signing on doesn't mean that everyone agreed with every recommendation, so I do say that as a caveat, that making policy is like making sausage. You don't necessarily want to know what went into it, but I'm going to share some of what went into it today. So background. So as I said, we did agree to write this statement in 2009. It wouldn't be finalized until 2013. Now, this, just to give you an idea, the original statement that I was working from the American Academy of Pediatrics was written in 2001, so really quite old, and really how fast genetics has been moving, really out of date. There was an earlier statement by the American College of Medical Genetics from 1995 They had actually worked on it with the American Society of Human Genetics, who did not want to partner with Lainie Ross AAP and Lainie Ross ACMG. There was no Lainie Ross on the ASG. But meanwhile, by 2015, given all the political issues that came out from our joint statement, they actually went and wrote their own statement, which 95% of agrees with the AAP ACMG statement. So much of what I'm going to say today is actually pretty much consensus talk. All agreed that the moral justification for any type of testing of children should be the best interest of the child. And in all pediatrics, we always use this phrase. There's only one problem with the phrase. We have no idea what it means. Do we mean that by best interest, we should only worry about those interests that are self-regarding for the child? Or does even a 4-year-old care how the family does? So are we allowed to consider other regarding interests when trying to understand what we're asking for when we want to act in the best interest of the child? Do we want to focus on the child's present interests or what those interests may be 20 years from now? So short-term interests versus long-term interests. In the UK, less so here in the US, they actually believe that child autonomy is part of the best interest, meaning that the child's voice should be heard even from a young age, even for clinical issues that there might not be disagreement between parents and physicians. So despite the fact that we all say the best interest of the child, no one really knows what we mean when we say that. So let's start with case 1, expanding newborn screening. So newborn screening, the history actually begins in the early 1960s with Bob Guthrie in Rochester, New York. He actually develops the test for screening for phenylketonuria. Phenylketonuria is an autosomal recessive genetic condition that can lead to developmental disabilities, seizures, eczema, if goes untreated. And the treatment is actually dietary. We just have to remove phenylalanine from the diet. He developed a test to screen for it. He also developed the filter paper that when we talk about doing a newborn blood spot, we still use today and is used all over the world. So it begins in the 1960s. He wanted it to be mandatory. So in part, so Bob Guthrie had a child with developmental disabilities, severe. He also had a niece who we'll learn later on actually had PKU that, of course, had been undiagnosed as a newborn, and so she was severely cognitively impaired as well. And he actually self-describes himself in writings as sort of a used car salesman, that his goal was to spread the word and to get everyone to sign on to doing newborn screening. And when he first started, he was working in Massachusetts. He was able to get 100% of the hospitals to voluntarily participate in an experiment on trying newborn screening for PKU. Despite that, he wanted it mandatory because he didn't trust anybody to continue to do it unless they were required to do so. And so with the NARC, they lobbied for mandatory PKU screening. This was not totally popular among physicians. They really didn't want the government telling them how to practice medicine on one side. And their other arguments were probably more realistic and more clinically valid was, we actually didn't fully know the natural history of the disease. The dietary treatment had never been tested in a clinical trial. It had all been done on anecdote. And we didn't even know the safety. We also didn't fully understand. In retrospect, it's easy to see how little we actually understood that some people have elevated levels of phenylalanine and don't have PKU disease and things of that sort. But anyway, he was a big advocate for it, and he won. So that by 1973, within 10 years of developing the test, 43 states had mandatory statutes. Today, all 50 states and the District of Columbia have mandatory newborn screening. So one of the important things when we think about should something be mandatory, should the state interfere and tell parents and physicians, you don't get to decide on this, we're going to make it mandatory. So one of the arguments about PKU is that without treatment, unless you diagnose it early, and the children may be asymptomatic for weeks to months, during which they're losing IQ points. So his argument was that we should have mandatory testing for conditions for which there is significant morbidity or mortality if treatment is not begun early. But that one question to that is that an adequate justification for a mandatory program? What we're saying in some ways by saying we're making it mandatory is that parents aren't smart enough to understand that we can prevent cognitive disabilities in their children. And I, for one, don't believe that. And so this whole notion of whether it should be mandatory or whether we should be very specific and directive in our counseling to encourage parents to screen for these conditions. We have to remember how rare these conditions are. So a parent who would refuse newborn screening, there's a 1 in 10,000 chance their child has newborn screening. So has PKU. So they're playing Russian roulette, but they're playing it with very, very few bullets. And so the question is a 1 in 10,000 risk, it's a much higher risk of a child dying from being in a car with their parents and things of that sort. So is that adequate? Turns out we didn't have any criteria for determining what should even be a public health screening program when Bob Guthrie started with this in 1963. It wouldn't be until 1968 that the World Health Organization came up with criteria for public health screening. And although it wasn't specifically designed for newborns, it has been used for the next 10 decades. And basically what we want is that there needs to be an adequate understanding of the natural history. There needs to be a recognizable latent or early symptomatic stage so that treatment can be effective. And we need to agree upon who needs to be treated. As I said, there are some people who might have elevated phenylalanine and not actually have PKU. But basically, these are the criteria that are used to this day, both here and really around the world, for justifying universal screening. Mandatory is still a controversial concept. In other parts of the world, it does require consent. So the moral controversies about expanding newborn screening is that the traditional conception really was about early treatment to prevent morbidity and mortality. But advocates have tried to expand newborn screening, arguing that that's a very narrow conception of benefit, that other things is knowledge is good, and knowing your child has a condition, even if it's not treatable, knowledge is good. One of the things that gets pointed out for newborn screening is that if you don't screen and a child has a rare condition, the parents are put on a diagnostic odyssey. They're complaining about symptoms. The doctors aren't finding any of the regular routine conditions, and so they may not get diagnosed for several years. And the other argument in favor of expanding newborn screening to lots of conditions is that it will allow for greater scientific study. The problem in this country is because our screening is mandatory, it's being done without consent, and not everyone wants to know about health conditions prior to onset of symptoms, and not everybody wants to be a research subject. And so this whole notion of mandatory newborn screening gets in trouble as we start expanding it beyond the typical PKU condition. So why did it expand? And one of the main reasons for the expansion was the development of a platform technology. And what that means is one technology allows with one blood test that we can test for many, many conditions at the same time. So it doesn't cost anything extra to screen. Now that's inaccurate because after screening we get false positives, so then we have to do additional tests. We sometimes find very mild conditions because we're screening so widely, conditions that might not need to be treated, and we might be over-treating and things of that sort. But it is the development of platform technology that made it seem cheaper, at least up front, for one blood test to be able to screen for many, many conditions. That also led to great inequalities throughout this country because those who adopted newborn screening tandem mass spectrometry early were testing for about 40 diseases in 2000, where West Virginia, which hadn't adopted platform technology, was only testing for 4. And so parents and advocacy groups started screaming, why should my child get sick and not get treatment because they live in one state versus another? So they were really a very strong force behind expanding newborn screening everywhere. The problem, though, is that some of the, quote, conditions that we diagnose may not actually be conditions. So my favorite example of it is 2-methylbutyryl-CoA dehydrogenase deficiency. No, I can't say that 5 times quickly. But 2-MBAD had, before MS came out, only 5 cases had ever been identified throughout the world. After the platform technology was started in Wisconsin, in the first 5 3/4 years, 27 infants were diagnosed, all but one of whom belonged to Hmong families. And these families chose not to treat these kids, despite being told that they had to put them on severely restrictive diets, and all the kids did just fine. So either they don't have 2-MBAD, but they have the mutation that goes along with 2-MBAD. And so that's one of the problems with expanding so quickly. And of course, it's really hard to do lots of testing when these conditions are so rare, right? I mean, so PKU becomes a common disease in the rare disease of 1 in 10,000. You start talking about something like 2 in MBAD. We originally thought it was like 1 in a million, of course, diagnosing all of those in Wisconsin. Question is, do they really have this disease? And the answer is probably not. Scott Grosse of the CDC talks about this shift from looking at newborn screening as a public health emergency. You need to start the PKU diet within the first few weeks of life where the child is going to develop cognitive delays. That's a public health emergency versus other conditions for which treatment might not be necessary for days, weeks, months, or ever. And he talks about this shift from a public health emergency to newborn screening as a public health service. And that's not to say that parents shouldn't be able to get this information, and that's not even to say that knowledge isn't good. Knowledge can be good, but it's no longer an emergency. And one of the problems with that, then, it reduces the argument in favor of mandatory screening. It much more supports allowing parents to decide, do I want to know what my child is going to suffer from at age 5 or age 10? The other risk is, even though it's mandatory, parents in all states but Nebraska are allowed to refuse it. Now, they have to know it's being done. They have to know to say no. Mandatory means you don't have to ask permission. Unfortunately, it gets translated to, you don't have to ask permission, you also don't have to tell anybody that you're doing it. And that's not what was meant, but that's what happened. So I did a study with a medical student. I had a medical student stand at the door as parents were leaving the newborn nursery, and they were only asked one question. Why does your baby have a Band-Aid on her heel or his heel? And the answers were incredible. Some thought we were testing for jaundice. No, that's not where you take a jaundice test. Some thought we were testing for drugs. No, we do that from a urine test. Some knew that we were doing some type of screening, but even those who knew, most of them couldn't name one condition that we tested for, even though it does include, at the time they did this test, sickle cell and cystic fibrosis, 2 pretty common conditions. And one parent was convinced we had taken blood from her child to clone her child. So bad practice not to educate people. And the reason it's so bad, not just that we leave parents with these misconceptions, but when we call them 2 days later with a positive screen, we think it's a medical emergency. We want them to come back immediately. But if they weren't told why it was being done, harder to convince them. And I live in Chicago on the south side, and when we try to call parents back in 48 to 72 hours, over half of the phone numbers are either disconnected or wrong numbers. So people aren't even giving us accurate information. If they understood, and we might need to call you in 2 to 3 days to prevent your child from developing developmental disabilities, they might be more interested in making sure we can contact them. And finally, the whole idea of just expanding because we can forgets about all the other costs of newborn screening, including the false positives and the stress it causes family, the identification of mild and atypical cases that may remain asymptomatic for life. So newborn screening has always been felt that it shouldn't just be viewed as a test, it should be viewed as an entire system, and we lose that as we move to this very expansive screening. So in summary, mandatory newborn screening should focus on conditions for which early treatment can reduce morbidity and mortality on the basis of being in the child's best interest. The use of newborn screening to identify other conditions creates, in a sense, what has been known in the literature as patience in waiting. And whether the benefits outweigh those risks is much more controversial. So what did the AAP-ACMG statement say? It said that parents should be asked to give permission. It didn't use the language of consent deliberately because, again, sausages are being made. But it did talk about the more important than getting permission was the need to educate. Now, the problem is, I will argue that unless we have to ask your permission, we oftentimes don't even talk to you about it. And so the only way to ensure education is going to be to require us to get your permission to test. Okay, so that's the end of newborn screening. Now I want to look at predictive genetic testing. So the AAP, and as I said, in the ACMG agreed that any testing should be based on the best interest of the child. And remember, we have difficulty agreeing on what best interest means. I also told you the ASHG wrote their own statement, and they also said it should be based on the best interest. And they also said defining an individual's best interest is often complex and controversial. So we're back to that. So here, is the original statement about predictive genetic testing from the ASHG ACMG test in 1995. That's what we're working on 15 years later. Until more information is available regarding the risks and benefits of genetic testing, the provider's guiding principle continues to be primum non nocere-first, do no harm. Thus, when faced with uncertainty, the provider may be obligated to avoid the possibility of harm rather than to provide unclear benefits. There may be rebuttable presumption to defer testing unless the risk-benefit ratio is favorable. So basically, what this statement says is when you're faced with uncertainty, when you don't know whether the harms or the benefits outweigh one or the other, you shouldn't test. The statement also says, if the balance of benefits and harms is uncertain, the provider should respect the decision of competent adolescents and their families. So what the statement then says, if you're faced with uncertainty, let the family decide. So in the first bullet, it's the doctor should decide not to test because it's uncertain. In the second bullet, family should make that decision. There's only one problem. These sentences are in the same paragraph. So I have no idea what they meant. I asked one of the authors of this joint statement, and he looked at me, and his comment was sausages were being made. I said, I still don't know which way I'm supposed to go. He said, just rewrite the statement. And that's what we did. Historically, predictive genetic testing of children was considered taboo. Basically, they didn't feel that you should get information about a child now that won't affect the child immediately. But I'm going to argue, and the statement is going to support, that all predictive testing is not the same. There's a difference about predictive genetic testing of an eye cancer like retinoblastoma that's going to present in the first 3 years of life versus predictive genetic testing for breast cancer that's not going to appear for several decades, right? And so Rick Kodish, a prominent pediatric bioethicist, talked about the rule of earliest onset, that we should only be screening for people at an age at which their cancer may begin to present. Predictive genetic testing also may differ in how we think about it and whether we should mandate it or whether we should even offer it on whether it's treatable versus not treatable. The idea of being forced to get a test and then being told, well, there's nothing we can do, go home and deal with it, doesn't seem very satisfactory. There's also a difference about doing predictive genetic testing in families at high risk. So if a father has retinoblastoma, it's an autosomal dominant condition, there's a 50% chance the child will have it. That's very different than the 1 in 5,000 in the general population. And so are these distinctions necessary? As I said, they weren't done in the earlier statements, but we thought it was important for this updated statement. So I want to look at two conditions that present in early childhood, retinoblastoma that I've been using as an example, and Duchenne's muscular dystrophy. So beginning with retinoblastoma, as I said, it can be a new mutation or it can be autosomal dominant. If diagnosed early, retinoblastoma is treatable, even if the eyes may not be salvageable. Before we developed a genetic test for retinoblastoma, we treated any child whose parent had retinoblastoma at high risk. And what that meant is we were going to test their eyes every 3 months, looking for what we call a white pupil. And we were going to do that every 3 months for the first 2 years. Then we were going to go to every 6 months. And we were going to do it until the age of 5, at which point we could tell the parents, good news, your child obviously doesn't have the retinoblastoma gene. But now we've developed a gene test so that we can prevent having to do eye exams on half of the children who are born to parents with retinoblastoma. And so you're probably sitting here thinking, so what's the big deal about doing an eye test? I mean, you're just looking in the kid's eye, right? And the answer is, well, it is a big deal because try to get a child from 9 months to 2.5 years to sit still while you're sitting there staring in their eye. And the answer is we do most of those under general anesthesia. And we've come to learn that general anesthesia has risks, particularly when done in young children. So it is not a totally benign procedure. So it's great that we only have to do it in half the children, and we know which children are at high risk and which children aren't. So here's a case study. RB is a well-appearing 6-week-old boy who you're meeting for the first time. The family history is remarkable for dad having retinoblastoma and having his eye removed as an infant. You recommend genetic testing, and the mother states they were offered such testing in utero, and they refused, and they now want to refuse. So one of the things is, why might the parents refuse prenatal genetic testing? And that's because they might not have cared. They were going to have this child. This was a wanted child. And if the child was going to have an eye cancer, it could be treated. They didn't want to do testing because prenatal testing has risks. So that makes sense. But now the child's out of the uterus, and now if the child does have that gene, at very high risk, over a 90% likelihood that the child will develop cancer. So clearly parents can refuse prenatal testing. Can they refuse testing of their newborn? Well, it's probably best, that best interest concept, it's probably best to get a genetic test result and to know which children you have to do an eye exam. But what if the parents are against it because maybe they don't believe in genetic testing, they're afraid of discrimination, but they're willing to come in every 3 months? So what that means is you're going to be putting some children at risk that isn't necessary, including anesthesia, but you're also going to be picking up those kids who are at high risk. And so while most of us would say that's not ideal, most of us would also then say it's good enough. And so that's one of the reasons why I hate the concept of best interest, because we really don't hold parents to a best interest. If they agree to come in every 3 months, nobody's going to take protective custody of these children. We're going to say that's good enough, and we're going to see you every 3 months. But if you don't show up, then we're going to get the state involved. So that's very different. I want to compare that to Duchenne's muscular dystrophy. This is an X-linked recessive condition of complete penetrance. It's about 1 in 3,500 male births. Girls are rarely symptomatic, but they can be. Infant males are asymptomatic. The onset usually begins in early childhood, around toddler age. And without treatment, they'll usually require a wheelchair by adolescence and death in early adulthood. So treatment, up until 6 months ago when I gave this talk, was the only thing we can do are steroids, and they can help with ambulation, but they don't necessarily prolong life. In September of last year, they passed the first drug, etaplirsen, I can't pronounce it, an antisense oligonucleotide in patients who have a specific mutation. It's about 13% of boys with Duchenne's muscular dystrophy. And what it's supposed to do is skip the part of the gene that's wrong, and so they get a shortened dystrophin. Whether that's clinically significant is still up for debate. It got approved because of a lot of political pressure, and it was approved on, quote, statistically significant increase in dystrophin, but the drug company is required to do further testing to confirm that it has clinical benefit. Just because you can lengthen the dystrophin doesn't necessarily, so that's a secondary endpoint. We don't know if it's actually going to really help these boys with ambulation. We hope it will. In February of this year, so 2 weeks ago, just to make sure I updated my slides, deflazacort was approved by the FDA. That's a steroid for boys over the age of 5. But I should say that we've been using steroids for over 10 years. And in fact, this drug has been on the market for over 10 years, but now it's been specifically approved for use in muscular dystrophy. And what does that mean? Well, it means that the price went up dramatically. Okay. So imagine parents request testing of their 6-week-old son for Duchenne's, and they give you a history of a maternal nephew recently diagnosed at 6 years of age. And so then mom goes and gets tested because if her nephew has it, that means her sister is probably a carrier, although there are some spontaneous mutations. But her sister is found to be a carrier, which means that she could be a carrier. She gets tested, she's found to be a carrier, which means that she has a 50% chance that any of her sons will have Duchenne's muscular dystrophy. So when we think about should we be testing babies, we have to think what are the pros and cons of testing at 6 weeks, because remember, these kids are going to be asymptomatic for at least the first year of life, although some will argue that they may be a little slower in speaking, and they may even be a little slower in walking, and that if we diagnose them early, maybe we could start some type of experimental treatments. But we want to think about what's the advantage of, in a sense, predictive testing for something that's going to start, but we might have a year to 2 years. So you can imagine some parents thinking, I want to live in a honeymoon phase. I don't want to know whether my child is going to end up in a wheelchair in adolescence. I'll go to the doctor, and when we first start seeing symptoms, if we start seeing symptoms, then I want to be tested. And some parents are going to want to know immediately. And why might they want to know immediately? They might want to plan. We're about to buy a new house. Do we buy a ranch or a 3-story house? If we know a child's going to be in a wheelchair, we might make one decision. If we know a child's not, we might make another. So those are some of the family perspective. And then finally, one last question would be, should we be doing this as part of newborn screening? No treatment is needed for the first 2 to 5 years of life, but it could give parents information not just about whether to buy a ranch or a 3-story house, but it also may give parents information, for example, about family planning and things of that sort. So what are the advantages? There's early diagnosis, they can get genetic counseling, the value for practical decisions like the house, participation in pre-symptomatic experimental trials, starting treatment early, avoiding that diagnostic odyssey, and giving them time to prepare. What are the disadvantages? So the early use of steroids before the child becomes symptomatic is actually quite controversial, and notice that the first drug that was approved was over the age of 5 years. Because you usually want to wait until the child has achieved motor milestones, because steroids have other side effects other than prolonging ambulation. They lead to obesity, they lead to cataracts, they lead to decreased bone density, et cetera, et cetera. There were concerns that diagnosis may lead parents to reject their children, although in Wales, where they had 26 years of newborn screening, we can talk about why they stopped it, but 26 years, they have no evidence that it interferes with infant-child bonding, infant-mother bonding. There is the potential for stigma or discrimination of children. Of course, it can also lead to more services. So there are advantages, there are disadvantages, which leads one to say different parents are going to vote differently about this. And if that's the case, then clearly it doesn't give a justification for including it in the mandatory newborn screening. We probably want to get permission for doing it early on. Once the child's symptomatic, it's a very different story. So can parents refuse prenatal testing even if they know they're at high risk? The answer is yes. Can parents refuse testing of their newborn? Absolutely yes, because there's nothing we're going to want to do. The interesting question here might be, can parents demand testing? Because remember, Rick Kodesh said the rule of earliest onset. If we're going to use the rule of earliest onset, we really shouldn't be testing these kids till they're closer to 2. But the fact is that whether we test them at 6 weeks or at age 2, it's the parents who are making the decision, which is very different than something like BRCA, breast cancer, where if we test them at 6 weeks, the parents are making the decision. If the woman comes in at 25, she's making the decision, right? So when we're talking about early onset conditions, we're talking about things that parents are going to be making the decision regardless. And for some parents, knowing early may have more benefits than harms, and for other parents, knowing early may have more harms than benefits. So currently, you can demand testing, but only if you're high risk. It can't be, doc, I was scanning the web last night, and here are the 5 conditions I'd like you to test my child for. I read about, Wilms tumor, neuroblastoma, Duchenne's muscular dystrophy. I always laugh. I say to my husband, the difference between a pediatrician mom and every other mom is I worried in specifics, and other moms worry in general. Moms always worry, are their kids healthy? I had specific concerns, right? So I'm always looking for my kid's white reflex. Other parents are just looking, is my kid healthy? So no, they would not have tested my daughters. I didn't have sons, so it really wasn't an issue, and I wouldn't have asked for it. But anyway, should we include then Duchenne's in routine mandatory newborn screening? And I would argue no. And part of it is because it's mandatory, and different parents are going to say what's in their child's best interest, and we're not going to agree on it. Nevertheless, as I mentioned, they had done it in Wales. There had actually been numerous pilots over the years around the globe. Most of those required consent. We do not have a system in place in this country to have a real informed consent conversation in the newborn period about all the conditions we test for. So on that basis alone, I would argue it's inappropriate to be including it in our universal newborn screening program. So in summary, there is a difference between high-risk testing and screening of the general population. And one of the interesting things about this difference is this. In a family where a nephew has Duchenne's muscular dystrophy, that mom's worrying in specific, does my son have Duchenne's, right? If I walked into the nursery and said to you, hi, Mom, congratulations, you have a healthy baby boy. But the fact is that 1 in 3,500 boys will develop Duchenne's muscular dystrophy. Would you like me to test your child? And then I described Duchenne's muscular dystrophy. You're freaking out. I thought you said he was healthy. I said, well, I think he is. He still has this 1 in 3,500 chance. And most of us are relatively innumerate in this country, and you agree. And then a week later, I come back and I say, good news. Your child is not at risk for Duchenne's muscular dystrophy. And you say, phew, thank goodness. But in a sense, you never were afraid. I created anxiety, and now I took it away. I didn't really benefit you. In contrast, if you know your nephew has it, and we test your child, you're sort of, when I tell you your child is not at risk, you're really relieved. So there is a big difference about screening in the general population versus in the high-risk population. And so I would argue that consent needs to be required. There are psychosocial benefits and risks of knowing, and it's families, not clinicians. So going back to that 1995 statement, they got it right in the second part, that it's families that need to decide whether or not the benefits outweigh the burdens. Families should focus on the child's interests, although the family's interests are also not to be ignored. The idea of what type of house to buy is really not just about the child, but also about the family. And I do want to point out that we're arguing about a 1.5 year difference, whether we do it at 6 weeks when the child is asymptomatic or 2 to 3 when the child starts showing symptoms. Either way, it's the parent who's making these decisions. So what does the AAP-ACMG guidelines say? Parents or guardians may authorize predictive genetic testing for asymptomatic children at risk of childhood-onset conditions. Ideally, the assent of the child should be obtained. Clearly not an example like Duchenne's, but in something that might present in adolescence or something of that sort. So very much tolerant. So again, we started with all predictive testing is wrong, and our new statement now says sometimes it's not so bad. Compare that to doing predictive genetic testing for late-onset conditions. I think I skipped a whole slide. So you can think here either about BRCA, breast cancer, or you can think about Huntington's disease. Huntington's disease being a form of early onset dementia. It's autosomal dominant, which means that 50% of children born to families with this gene are at risk. So what are the pros and cons of screening? Well, 50% of the time they're going to test negative, right? So it's going to relieve anxiety. It's going to relieve ambiguity. Turns out when you're in a family at high risk for certain conditions, knowing you're at risk obviously is anxiety provoking. It turns out knowing you're at risk but not knowing whether you are a yes or a no is more disturbing than even knowing that you have the gene. People find ambiguity worse than anything else. So I always use the example, remember when you were waiting to hear whether you were getting into this DO program or not? That's a very anxiety-provoking time. Imagine you're now living like that for decades, which is what families with high-risk genes often do. What are the cons of testing a child for an adult-onset condition? It takes away the child's decision. Not everybody wants to know whether they have the family gene for breast cancer or the family gene for Huntington's. There's also the concern that parents may seek inappropriate treatment. There's the potential for employment and insurance discrimination, and it may be harmful to self-identity. It's interesting that ethicists and pediatricians alike all express much greater concern for a parent wanting to test their child for a breast cancer gene than they do for the Duchenne's muscular dystrophy gene. And part of that is because for the Duchenne's gene, the parents are going to be the deciders regardless of when the testing happens. But with breast cancer, it may be the child as an adult gets to make the decisions. We're also worried, what does it mean for a mother to know my daughter's going to develop is at risk for high risk for developing breast cancer? Remember, not everyone who has the BRCA gene goes on to develop breast cancer. What does it mean to know that for decades? And how do we ensure that the information is transmitted in a way that, in a sense, promotes her, empowering her to make good healthcare decisions like early mammograms? There's also the concern of privacy. So the child who's going to develop Duchenne's muscular dystrophy doesn't have a right to privacy against his or her parents because the parents are going to be taking care of the child at age 6 and at age 10. But the young woman who may not develop breast cancer until her 30s has a right to privacy against even her parents. And so we might not want to be doing adult-onset testing. The problem is parents don't distinguish as clearly between a disease that presents at age 6 and a disease that presents at age 25. To parents, you're still my child whether you're an adult or not. And some of you feel that every time you go home and visit mom and dad. They still want to micromanage your life, and the answer is yes. And so parents might be thinking, you know, if I get her BRCA tested when she's a baby, then I can make sure, I could be the nag at age 25 and age 26. You need to be getting yearly mammograms. But if she doesn't have the gene, then I don't have to nag her. I can nag her about something else, but I don't have to nag her about the BRCA, right? So parents may feel that their responsibilities go way beyond just because the kid hit adulthood. It's also, as I said, very stressful for families to live with this ambiguity, looking at your child every day and saying, did I pass on this gene or not? And yet, we do have this belief that as adults, we have a right to healthcare privacy. And so we really don't want to allow parents to be testing their children for adult-onset conditions. And that's how the AAP-ACMG statement speaks. So for childhood onset, the answer is yes, you can do predictive testing, parents. But when we talk about adult onset, we wrote predictive genetic testing for adult onset conditions generally should be deferred unless an intervention initiated in childhood would reduce morbidity or mortality. And we would have liked to have ended there, but we do know that for some families, the ambiguity is so anxiety-provoking and really makes it that parents can't effectively parent. And so we wrote, an exception might be made for families for whom diagnostic uncertainty poses a significant psychosocial burden, particularly when an adolescent and his or her parents both agree in their interest in predictive testing. So we weren't going to allow them to test their 6-year-old, but their 14-year-old who assents to the testing, and the parents, and it really is debilitating and really interfering with the adolescent going through developmental stages. We said in rare conditions, it may be appropriate. So clearly, lots of changes in the new statement based on, in a sense, a greater understanding of what we really mean by appropriate parental decision-making and what we really mean by best interest, or maybe best to call it good enough decision-making. The last case that I want to talk about is whole exome or whole genome sequencing. And you guys know this stuff much better than I do, because we didn't even, first of all, we didn't even know we only had 46 chromosomes until the 1960s. The first gene that was associated with a disease was cystic fibrosis in 1989, and that was way after I'd finished medical school. So we know we have 46 chromosomes. We have approximately 20 to 25,000 genes that in every cell of our body are all of our chromosomes, and there's about 3 billion base pairs. Okay, so what's the difference between whole genome and whole exome sequencing? Our chromosomes include both protein coding DNA genes and non-coding DNA. In fact, only 1.5% of base pairs are actually translated into protein. We used to call the rest junk DNA because we didn't really understand it. So the exome consists only of the coding portions. The whole exome includes both the coding part of your gene as well as the rest of your DNA. So that's the difference. And most testing at this point focuses on exome sequencing because it's cheaper and it's much fewer base pairs. Usually it's being done to look for a specific problem that hasn't been able to be identified by other means. So we've tried chemical tests, we've even tried specific genes. We can't figure out why this child has this condition. And it's usually focused on areas of the exome or genome where the known mutations related to the symptoms have been found. Now, obviously, your whole genome has a lot more information. But to learn that information takes a lot of resources. It takes time. It takes looking through all the different variants. If humans only differ by 0.1% of 3 billion base pairs is still a lot of million base pairs. And there's a lot we don't understand. There's a lot of variants that we call them unknown significance because we know they're different than the majority of the public, but we don't even know if they're disease-causing or not. So why are we thinking of doing whole exome sequencing, whole genome sequencing now? And in fact, in some places, they want to even introduce it into newborn screening. And here's the answer. It's that the cost has dramatically dropped, that the first whole genome done as part of the Human Genome Project took 15 years and cost $3 billion, and now we can do whole exome sequencing in less than 48 hours for about $1,000. So it's becoming almost affordable. However, that's just sequencing. Then we have all the other costs, and those other costs include the need for molecular and computational biologists, geneticists, pathologists, and physicians with exquisite knowledge of the disease and of treatment modalities, research nurses, genetic counselors, information tech experts, system support specialists, among others. And this is a quote from an article. One does wonder how, in the clinical translation required for this practice to become commonplace, such a dream team of specialists would be assembled for each case. In other words, as Dr. Martis and colleagues wrote, even if the cost and speed of generating sequencing data continued their precipitous decreases, the cost of team analysis seems unlikely to immediately follow. And so she talks about the $1,000 genome, the $100,000 analysis, right? So let's look at what's happened. So this is only 6 years ago, the first case where whole exome sequencing helped a clinical diagnosis. It was a 15-month-old male who had what looked like Crohn's disease, but didn't have any of the usual genetic problems. And when they did whole exome sequencing, they found a hemizygous missense mutation that had previously not been discussed or associated with Crohn's disease. And it turned out that the treatment then, rather than the usual Crohn's medications, would be to do a bone marrow transplant, which was done successfully, and the child can now eat and drink. So an incredible case of, taking a child who was just being so debilitated by GI symptoms and now is doing just fine after a whole exome sequencing. And then 4 years speed up, and they talk about all the clinical cases and how many are being diagnosed by whole exome sequencing. And of course, every year we get better because we learn more about what those variants of unknown significance are, which are pathologic and which aren't. And they talk about, well, maybe we should even think about doing whole exome sequencing first because it's so expensive to do single gene, might as well just do them all at the same time. But that then leaves us with the problem that we often get a lot of more unknown meaning to a lot more genetic illnesses. So every time people say it might be cheaper to start with whole exome sequencing, I just want to remind you of the article, the $1,000 genome, the $100,000 analysis. This became really important because of the ACMG 56. So let me explain what that was. So in February 2013, the AAP-ACMG statement came out, and they had specifically asked us not to talk about whole exome, whole genome sequencing because the ACMG was in the process of writing their own statement on it, and they needed a lot more research. That's what they said. So, and we believe them. So shockingly, in March of 2013, they came out with their own report. And what the gist of this new policy was, so they needed a lot more research. They were able to do it in 27 days or less. The gist of the new policy was if sequencing is performed for any clinical purpose, you should look for 56 other genes that are associated with 24 inherited conditions because these are high-risk alleles. They said it didn't matter whether the patient wanted it nor whether the physician wanted it. They called it, quote, opportunistic screening. Those of us who were against it said it was a mandatory hunt for incidental findings, which was their language. Look at the title of the report, which is an oxymoron. You can't be mandatorily hunting for something that's, quote, incidental. So here's the list of the genes they wanted us to test for. What you need to know, rather than reading any of them, is that most are cancer or cardiac genes and most are adult onset. So for pediatricians, this is a real problem. What you're saying is we are mandating testing, predictive genetic testing for adult onset diseases. And I just told you the AAP-ACMG statement from a month earlier said we shouldn't do it in general and only under rare exceptions, right? And again, doesn't require consent of ordering physician, doesn't require consent of the patient. And the ACMG said, oh, you're misunderstanding us, Dr. Ross. It's like incidental findings in radiology. You order an abdominal film and you happen to see a small pneumonia in the lower lung field, you're not going to ignore it. But it's different. Like what Martis's article told us, in order to be looking for these genes, we have to then sequence these other parts of the genome. We have to then interpret it. We have to figure out these variants of unknown significance. It's not like it's already there. It takes a lot of work and a lot of resources. And it's not clear who's paying for it. So it wasn't just the pediatricians who were unhappy. The Association for Molecular Pathologists asked me to join on their statement because they want to know who's paying for it and what do you do as the person who did this sequencing when you call and the doctor says to you, but I didn't want this information. And then you try to call the patient and they said, I didn't want this information. And so who's supposed to take this information? It's also the case that these are genes that are high risk in high-risk communities. It turns out there have been two recent studies, one in 2013, one in 2016, that shows when you start doing high-risk genes in the general population, you find, just like we did with that 2-MBAD, that there are some populations where this isn't a high-risk allele. And in fact, one of the groups where we're finding that many of these, quote, pathogenic mutations are not high risk is in minority communities who have not been a major part of genetic testing and screening research in the past. So finally, the ACMG clarified their statement and said, all right, you have the right to refuse mandatory hunts. You can opt out. But it still said, but if parents want this information, they can get it about their kids because it may benefit them, the parents. Remember the canary in the coal mine. And I pointed out to them that this still contradicts their statement from a month earlier, which said predictive genetic testing for adult-onset conditions generally should be deferred unless an intervention initiated in childhood may reduce morbidity or mortality. So to the extent it's recommended to identify conditions in parents, test the parents. Children do not need to be the canaries in the coal mine. It denies the child's rights to an open future to be able to decide as an adult whether they want to know whether they're at risk for breast cancer or Huntington's disease. It denies this whole notion that they may choose not to know and that they have that right. And it takes away the right to privacy that as adults we have even against our parents. So if they want to offer this mandatory hunt, maybe they can offer it in whole exome sequencing for adult disorders, but in pediatrics we don't feel that it's appropriate at all. So let me conclude by ending where I started. Children are not canaries. They're also not tomatoes. So why do I say that? So in May 2012, the New York Times published this article that showed that the tomato has 31,760 genes, which is about 7,000 more than a person. So either tomatoes are more complicated than you and me, or we're more than our genes, and that there's a lot about genetics that we don't understand. I'm going to take the assumption that we are more than our genes, and children are valuable and vulnerable. We need to focus on the best interest, or at least their good enough interests. Main focus should be on their self-regarding, what's best for them, and not about what's best for their family. It's not to ignore these other needs. It's only to say that healthcare policy should focus primarily on the child's medical interests. So with that, I'll end and take any questions.
Anybody have a question? Why did they
stopped in Wales? That's a great question. So they stopped in Wales because of the lack of, they originally had huge amount of resources to work with these families. So you diagnose the kid, and then what happens in this system is we don't really want to see you until you become symptomatic or we're going to start treatment. And in Wales, they had an incredible system of support and counseling for these families. And as that resource went away, they started to realize that they might be doing more harm than good.
One more question? Anybody? Student?
It was also a weird thing, since I don't have a question right now. It was a weird thing. At the time they started newborn screening for Duchenne's, they were testing for PKU, hypothyroidism, and Duchenne's, because there was big interest in the neuromuscular community in Wales. If you ask me what the third condition should be, I might put sickle cell disease, maybe not in Wales, maybe I'd put cystic fibrosis, maybe I'd put galactosemia. There are a lot of other conditions I might have put before Duchenne's, and I think that also became a cost issue as well.
Last chance. All right.
Oh, right over there.
Oh, good.
Hi, so this might be more tangential, but let's say we do switch to more, from a mandatory screening system to, a consent-based screening system. How would we potentially change our culture to be more encouraging, of parents to know what is right for their children?
So I actually think it's a really important question. I don't think we need a 25-page consent form, but if I had to explain to you 40 diseases, it would actually be a 250-page consent form. I think what we need to tell parents, and that we need to have our newborn screening focused on conditions for which early treatment is necessary to prevent morbidity or mortality. So we shouldn't have Duchenne's, but yes, we should have galactosemia, and yes, we should have sickle cell, where we need treatment starting pretty quickly. Right? And so I think if you explain to parents, we do this testing for looking for weird, rare conditions. And if we find one, we're going to do further testing, because just because you get a positive screen, then we have to do diagnostic follow-up screening. And what we want to do is test your child. And if your child has a positive screen, we're going to be with you through this diagnostic process. And if your child's going to need treatment, we're going to be with you. And I think if you explain that, I think you're going to get 99% of parents to say yes. Now, that's not 100%. But you know what? We lose samples. We get incomplete samples. We have lots of mistakes, probably more than the 1% we're going to miss of parents who say no. And why do I think 99% of parents are going to say yes? because back in the day, there were 2 states that required consent for newborn screening, and they always got about a 98 to 99% uptake. Parents aren't stupid. If you tell them you're going to prevent a child dying or a child from developing cognitive disabilities, they want that information as much as you and I want it. They might not be as interested in diseases that aren't going to present till 20 or 30, or diseases that have no treatments.
Thank you. Please join me in thanking Dr. Ross.